Good morning. My name is Tamira M. I am the proud founder and CEO of To the Moon and Back Foundation Incorporated. I would like to welcome all of you to Dunwoody Perimeter Chambers' second session for the Return to the Workplace Post-COVID-19 series entitled Healthcare in the Perimeter. The Dunwoody Perimeter Chamber would like to thank Cox Enterprises for their generous support as a knowledge expert level sponsor for the series. It is my pleasure to be joined by an elite panel of movers and shakers in healthcare. I would like to introduce Dr. Kathleen Funk. Dr. Funk specializes in emergency medicine at Northside Hospital. Dr. Funk, can you briefly share your primary responsibilities with Northside Hospital?
Yes. Thank you, Tamira, for the opportunity to be here with y'all today to talk about the ongoing challenges for healthcare professionals as communities are opening up and the pandemic continues. So let me tell you a little bit about myself. I started in EMS and finished medical school in Texas, and then I came to Georgia to finish my emergency medicine residency at Emory University. I've been a full-time practicing emergency physician for the past 30 years. And after a short time in academic medicine, I've been practicing at Northside Hospital for the past 20 years. I completed training last year at Stanford University for a chief wellness program to promote healthcare professionals, wellness, and engagement. I'm currently completing a master's program through the University of Texas at Austin in healthcare transformation. So coming back to Northside Hospital, there in the 20 years I've been there, I've worked on a number of initiatives. I've developed protocols to help clinicians recognize and rescue human trafficking victims. And then we began working on a significant project to help with the mental health effects and stressors of burnout in healthcare. And then when COVID-19 hit, we rapidly shifted gears to start to support the resiliency of our health professionals in the face of the significant challenges and personal risks during the coronavirus. So as COVID-19 hit the US, Northside realized the need to quickly align our clinical expertise and operational strategies. So I was part of a core group of Northside physicians gathering information and working with the administration to shape our response.
Thank you, Dr. Funk. You have a very impressive background. Next, I would like to introduce Dr. Brian M. Rivers. He is the director of the Cancer Health Equity Institute at Morehouse School of Medicine. Dr. Rivers' interests include cancer health disparities, mobile health, integrated biological, and behavioral science. Dr. Rivers, welcome. Can you please briefly share your responsibilities with the Cancer Health Equity Institute?
Sure. Good morning, Tamira, and good morning, Dr. Funk. How are you? And I appreciate the invitation, and good morning to our audience. Yeah, thanks for logging in. So as mentioned, I'm Brian Rivers. I'm from Morehouse School of Medicine. I currently serve as the director for the Cancer Health Equity Institute, purpose to advance our understanding and knowledge of addressing cancer health disparities in basic science and clinical science, population science, as well as translational science for all populations, with the intent to really unearth why we have some groups that are disproportionately impacted by some diseases in comparison to others. So I've been sort of at this for the past 20 years. I recently retired from the National Advisory Council at NIH for the National Institute of Minority Health and Health Disparities. And I also recently transitioned as being chairperson for Minorities and Cancer Research Council, one of the constituency groups of the American Association for Cancer Research, the oldest cancer organization in the world. I'm proudly to say that I was not born in Atlanta, but I moved here from Buffalo, New York at the age of 5. And so I completed all of my early education in the Atlanta public school system, went off to Vanderbilt and got trained in integrated biology, and then finished up with a master's in public health from Morehouse School of Medicine, then went over to UAB and got my PhD in health behavior, from the School of UAB, School of Public Health. And so I'm excited to be back finally in Atlanta doing this work, and I look forward to the conversation we're going to have this morning.
Thank you, Dr. Rivers, and for all the work you're doing in health disparities. Last but not least, we have Heather Dexter, who has served as the CEO at Emory St. Joseph Hospital since 2015. Heather, can you also please briefly share your primary responsibilities with Emory St. Joseph Hospital?
Sure. So I have served as the CEO since 2015. So my primary responsibility is really focused on Emory St. Joseph's Hospital as a part of that broader system. I lead the team here in our operations and make certain that really my role is to make certain that our healthcare team has everything they need in order to care for the patients. I've really enjoyed this role. I've been in it for a few years now, but I have been at Emory St. Joseph's for 22 years. I have played a wide variety of roles here during my time, and was fortunate enough to be a big part of the transition into Emory Healthcare. So really got to help design what St. Joseph's was going to look like within the broader Emory Healthcare system, which has been a wonderful place to be, particularly during this time of COVID-19, because as we've found, that having a broader system allowed us to respond in a better way in terms of being able to handle supply sharing and load balancing of our patients. So I'm grateful to have been here as part of this hospital, but also a part of that broader system.
Thank you, Heather, for all the important work you're doing in healthcare. So our first question, what have been the greatest adjustments and or barriers since the COVID-19 pandemic? And Heather, we're going to go ahead and kick it off with you.
Sure. So I would say the adjustments for us began with things like process redesign and facility changes. As Dr. Funk will let you know, we've had to really change the way that we are providing care. We have created different workflows and processes for our patients with respiratory illnesses, which started as just how we move them from one place to another in the organization, and then became things like dedicated waiting spaces that were built literally almost overnight within the emergency room, and then to tents and trailers sitting outside of our emergency room so we could make certain we were prepared for a surge. We also had to make changes to our inpatient care units so we could dedicate these patients to certain units to ensure the safety of our patients, but also to ensure the supplies were available for our protective equipment that our staff needed. And that comes to some of the challenges that we faced. In initial days of seeing COVID patients, we had a very hard time sourcing what we needed for our caregivers. We couldn't find personal protective equipment, and so we had to start looking for alternatives, and then ultimately asking our caregivers to reuse items that were not intended for reuse. Those were huge challenges. Another challenge was just getting the testing that we needed to care for these patients. The testing wasn't available in terms of capacity for a long time as we started to see surges of patients. And then as it was available, it took a long time to get results back. So caring for these patients safely was always a concern for us, both for our patients as well as our staff.
Thank you, Heather. Dr. Rivers, can you please share?
Yeah, sure. And so, I echo a lot of what Heather just mentioned in terms of just, the structural changes that had to take place. But then, being at a school of medicine, we also had other groups and constituents that we had to concern ourselves with. One, especially our learners. And so we made, of course, adjustments and transforming the platform of being in the classroom to moving more to a virtual setting, which was a huge adjustment for many, not only from on the student side, but then also on those who were providing the lectures for the course. But, I must say, they did an outstanding job in making that transition in early spring. Our other group that we are very much concerned and alerted to beyond our clinicians, are the researchers as well, and how we help or continue the facilitation of NIH and other federal agencies funded research. If you're not at the bench, then the research cannot take place. And so we had to come up with some very novel, pathways and novel approaches to ensuring the continuation of not only, the research at the bench, but then also our population and clinical-based research as well. And so a lot of the processes, if you will, were able to be converted to the virtual platform, but with the same level of integrity that we would if we were working in person. But it was a difference, and it took some adjustment, especially as it relates to really engaging patients in the clinical setting. And then lastly, I would just like to mention the adjustments we had to make with engaging our community. We're a school known for our social mission of how we engage diverse constituents. And, with a lot of the misinformation that was going forward, With everyone operating in real time, the community was demanding answers. We were trying to provide evidence-based answers as best as possible, but everything was happening in real time. So we really had, some key takeaways from this experience in terms of things that we can put in place, going forward that would bode, I think, very well for us.
Thank you, Dr. Rivers. And Dr. Funk, can you please share your adjustments? You need to come off of mute, Dr. Funk. We want to hear what you have to say.
So I think we experienced a lot of the same problems logistically and in terms of keeping normal operations going that both Heather and Brian experienced. These were really, really challenging times, and we all kind of pulled together. From a clinical point of view, I have to say that COVID-19 is literally unlike any other disease process we have seen in our lifetimes. The challenges were not only the higher numbers of sicker patients with higher mortality rates, but the clinical challenge of finding different ways that these illnesses can present, attacking almost any organ, having to get the algorithms straight. And so very, very early on, from the board on down, we took an all hands on deck approach in early March. And we began not only following CDC and World Health Organization recommendations, but where recommendations weren't available, we were literally canvassing across the entire nation and even across the world, reaching into places we had previously trained or lived, to other colleagues in hotspots in Washington, New York, California, Louisiana. One of our board members is an OBGYN doc, and she actually talked to an uncle in the UK to find out how they were managing things. And through her, we managed to get an early copy of the manual written by the Chinese scientists for how they were managing things. And so we used all of those things. It was an interesting sort of information grab because there was not a lot of observational studies, in fact, almost none actually printed at the time we were trying to lay forward our algorithms. And so we had actually kind of 6 primary areas that we changed. We postponed our elective cases early to preserve our PPE and ventilators. We developed COVID and non-COVID ICUs and floors. We limited visitors, closing most of our entrances to foot traffic and screening people who came in. We were the first in Georgia, I think, to give convalescent plasma for COVID with antibodies given to some of our sicker patients that were obtained from people who previously had COVID. Our chief of pathology, we had the same testing problems. So our chief of pathology developed a testing media and swabs to allow us to collect those samples better in-house. And eventually we were able to move the testing in-house as well. Our critical care docs and our ED had to collaborate so that we had one approach, compiling all of our data and all of our experiences from around the world, even as our first COVID patients were rolling through the door, to understand how to clinically approach these patients. It was challenging, but it was a cooperative experience.
Right. I'm glad to hear you all were able to make adjustments and be flexible. We know prevention is the key when it comes to healthcare. What encouraging message would you tell the patient who is hesitant to visit your facility to receive preventive care services due to the fear of being impacted by COVID-19? Dr. Rivers, can you please kick us off with this question?
Sure. And so what we're saying basically to our the populations that we serve is that we are following the guidelines that are in real time, that have been issued by the Centers for Disease Control. We have adjusted our clinical processes. We've adjusted our processes in the context of research, and we adjusted our processes in the context of how we engage, our learners. I think unique for Morehouse School of Medicine is that we have returned, to campus, and we have resumed operations as normal. So what did that look like? So a lot of those preventive strategies we actualized for the entire workforce. So in order for employees to come back to, Morehouse School of Medicine, everyone had to be tested, right? And so we tested our entire workforce. We've rearranged processes where now individuals are limited in terms of the structure of the meetings, how many individuals could be in an elevator at one time, or how many people can actually travel down a hallway together. And these same things, these same process adjustments and redesigns have taken place in the clinical setting as well. And so patients can rest assured that we are following evidence-based guidelines to ensure the safety of everyone coming in the clinic and their level of interactions, and they can be, confident that they will be protected and their health is of utmost importance to us.
Thank you, Dr. Rivers. Dr. Funk, can you please share?
Yeah, I think we need to separate this issue from preventative care and acute care. We've seen across the nation, but we've seen it here in our own community, people waiting too long to come to the emergency department and suffering dire consequences. EMS shared with us early on that they were seeing a higher number of refusals of transport. So people were calling EMS out, wanting to have that reassurance that they weren't going to die, but EMS doesn't have the same testing capabilities. So they would call them out and then refuse care, and EMS would sometimes later go back to the same call to cardiac arrest. And so there has seen increased cardiac arrests. And so this is an ongoing problem. It's getting a little bit better as we're trying to reach out to the community and tell them, if you are sick, you need to come in. It's always a good idea to call your primary care doc if it's not, dire emergency like chest pain or shortness of breath. But ultimately, we've worked really, really hard to make it safe for people to come to the hospital. The air inside our ED rooms, all of our exam rooms, they circulate once every 2 to 3 minutes. We clean thoroughly between. We wait 20 minutes in addition to the wait time before we clean. So it's almost an hour turnover between patients when we're cleaning our rooms now with these COVID precautions. So we're, the fact that we are making our employees and patients wear masks, we're disallowing ED visitors, and unfortunately, a lot of people in the community not wearing masks and social distancing. At this point, you're more likely to get COVID-19 from the community source or close contact than from coming to the hospital. So by all means, if you need to come, please come. On the preventative side, we know that preventing disease and keeping good control of chronic disease is the best way to avoid the need for emergency care. So you've got to, connect with your primary care doc. We've shifted a lot of our preventative care to telehealth, as a lot of facilities have. And so we just need to make sure that we're, getting the care that we need.
Thank you, Dr. Funk. And Heather, let's hear from you.
Very, very similar to the experiences that my colleagues have had. We have all the same preventative measures in place to really ensure safety within the hospital. Same cleaning techniques, same process for leaving rooms to be empty in between patients. We are social distancing everywhere. We've done a good job of taking furniture and tables and everything out of the hospital, so you can't even have the opportunity not to social distance. All of our visitors, all of our patients, all of our employees are masked. They're temp screened, so we can ensure that we have people coming in the door who are not exhibiting symptoms. That includes our employee population, and that's a daily screening for all of our visitors and our employees. We're also testing all of our patients. So anyone having a procedure or any inpatient that's coming into the hospital, we're testing so we can continue to get those patients into the dedicated units that we have, so that we don't have cross-contamination of our patients. Like Dr. Funk, I would say that our patients are actually safer here in the hospital environment than in many cases out in the community, both within the hospital and our outpatient settings. So we've put the same processes and safety measures in place in all of our outpatient settings. With masking, we don't allow visitation right now. We have very few exceptions for that because we don't want to add extra people within our facility that don't need to be here. And so we've put those measures in place. We've also been leading in some of the research that's happened across the world in COVID-19. We are currently testing a vaccine here at Emory, as well as we have an antibody test that we are using with all of our employees right now. So similar to what my colleagues have experienced, we're trying to put all the measures we can in place up front to ensure safety within our care locations.
Thank you all. It's great to hear about your safety measures because that's so important. The next question, we're going to turn to the economic impact, and this question is for Dr. Funk and Heather. What type of fiscal impact has COVID-19 had on your organization? And if Dr. Funk, you can start for us.
Sure. I have to say this pandemic has hit everybody hard. I can't imagine any business that is operating business as usual at this point. Everybody has lost fiscally and lost deeply. I think without a frame of reference, the actual numbers are less important than the fact that we are all dedicating significant resources to getting our community through this. Northside Hospital has been very sensitive to the fiscal needs of our community. One example is that our concern for our employees, who are all a part of our community, both at Northside and in the Atlanta area, not wanting to contribute to the burden of unemployment. Northside made an early decision to not furlough any employees. So instead of doing that, we reallocated them. So we took a nurse that was in a clinic that maybe was an ICU nurse years ago, and we paired them with one of our current ICU nurses to help relieve some of the burden of the added intensive care needing to be provided. Things like that allowed us to just shift our employees around to the areas of the greatest need. I'd like to add too that fiscally we're seeing hospitals, especially rural hospitals, closing their doors. Some hospitals, just like some other businesses, will not recover. While the government's tried to help out, it's a drop in the bucket to what everybody is losing in this endeavor. So we've got to remember that whatever the cost is to us as an organization, we have a responsibility to remain financially viable for our community, because the greater fiscal impact is on the individuals and families, many of whom have lost their job or gone out of business.
And Heather, can you please share?
Yeah, we also saw a huge impact across Emory Healthcare for the same reasons. We were canceling all of our elective procedures. We went from our normal volumes to about 20% of normal of our procedures. Our emergency department dropped about 50% of our normal daily visits, as well as our inpatient census went down to about 50%. And of those 50%, 30 to 40% of them were COVID patients, which took a lot more resources because our staffing models had to change and the personal protective equipment that we had to use was more intensive. So as we began to look at what was happening to Emory Healthcare over the first 2 months of taking care of COVID-19 patients, we modeled out what would happen if we continued down the same path of lower revenue, but equally as high or higher expenses. And for us, if we had continued that path through August, it would have been a $660 million loss of revenue for our healthcare system. So that didn't change how we were reopening, but it did make us look at what do we need to do to be fiscally prudent in order to be viable in the future as a healthcare system. So we have made some recent changes. In May and June, we started feeling it was safe to open up to some of our procedures that we had put off for a long time. So we've been doing, for the past couple of weeks, about 75% of our normal volumes. So we don't anticipate that we'll hit that 660 million loss number now, because we have been able to do more of our business. But that business still is costing us more because of everything we've had to put in place for safety measures. So we still see ourselves in a big hole as we finish this fiscal year for us at the end of August, and are already starting to work on what do we have to do in the future to make certain that we can keep high quality care, but we can do it while bending the cost curve to get us back into a more viable state.
Thank you both. This next question is for Dr. Rivers. COVID-19 has increased the exposure of the unmet needs of underserved populations. Can you please share how Morehouse School of Medicine has used telemedicine to reach the most vulnerable populations?
Sure. And, that's one thing that, I guess, even in the midst of this pandemic, just to realize that, some individuals are faring much, much worse in comparison to others. A pandemic within itself is just, a horrible event within itself. But then to realize that there are some populations, African Americans, Hispanics, those in rural areas of Georgia, that are suffering disproportionately for a variety of reasons, whether it's an existence of multiple comorbidities, or if it's due to the social determinants, as we call them, that they're encountering, living in poverty, living in densely populated areas where they're not able to effectively social distance, or just being an essential worker who had to continue efforts just to maintain their household, especially if they were the sole breadwinner for their household. And so we've seen this impact, and to make adjustments in real time without compromise, we turned to telemedicine, and we amplified our telemedicine efforts not only in urban areas but in rural areas as well, such as Columbus, Georgia, as well as Albany, Georgia, where we have clinics, and our residents are serving in those different capacities. And we also utilize some of the boots that we have on the ground. We have a very robust community health worker program, that have entree into very diverse neighborhoods that can serve as liaisons, not just for, education and information, but then also to navigation to other essential services that they may have need of. And then, of course, we're engaged with our community partners. And so, we've activated our community partners. We are working with them, conducting town hall meetings in community-based settings, involving them in research grants that are coming out around COVID and looking at the impact on vulnerable populations. We're involving them in the conduct of these research studies to better understand what are the gaps and how we can best utilize technology or some other format to help meet their needs. Again, this is something that's dynamic, it's happening in real time, but I think this whole notion of health disparities was really amplified on the national level during this pandemic, and I think it will continue to remain a part of our national conversation, realizing that we can't go back to business as usual in terms of health infrastructure, but we have to make some needed changes to ensure that we're addressing the needs of all individuals.
Thank you, Dr. Rivers. Dr. Funk and Heather, can you share how your organization used telemedicine to continue offering services during COVID-19? If Dr. Funk can start off.
Sure. So Northside invested a lot in our telemedicine capabilities since the pandemic began. For the most part, we're getting a positive response from patients on their experience. We're learning as we go along with our patients. We're learning what works, what doesn't work, and we're adapting. One of our primary care clinics took the lead on calling potential COVID patients that are discharged from the emergency department. So they came, they couldn't get tested because we didn't have testing available. We're still even at a point where we're not testing a lot of the people we send home if they don't meet clinical criteria for admission. And so if they're, they don't have a low oxygen, they don't require the ICU, they don't require inpatient care, we're sending them home. And through telemedicine, our primary care clinics are following up with these people and monitoring them day by day to get them through that critical period where the inflammatory response occurs, to be sure that they don't need to be sent back to the ED, because we are seeing some people that are missing that mark, just not that necessarily have been to us, but they know they're sick and they're waiting, but they wait so long they end up in our ICU by the time they hit our door. So all in all, we've completed over 70,000 telehealth visits across a little over 150 practices since the pandemic began, including not only follow-ups from the ED, but also follow-ups from surgery. We've got a lot of rural communities, especially around the Cherokee campus, and the same telehealth capabilities are being used there. And I just want to point out that in terms of all the rural hospitals suffering so badly in Georgia and across the nation, we're getting inroads in understanding how telehealth can really inexpensively bring quality care to these communities, and sort of close those gaps that we're seeing in care. So we've been talking actually with one of our VPs about the value of bringing mobile telehealth units backed by physicians, advanced practice providers, and specially trained procedural medics to some of our rural communities that have lost their clinics or hospitals. So it's just an initiative that we're kind of beginning to work on. We all need to develop to support the development of telehealth for that reason, I think.
And Heather, can you please share?
Yeah. We at Emory have been working on telehealth for about 10 years now. It's been very, very slow progress. And we feel like we made more progress in 10 weeks than we made in 10 years previously. Our physician group practice went from their normal visits down to 50% of their visits. And it was a combination of in-person visits and telehealth visits. And at the peak, we were seeing about 50% of those visits be telehealth visits across all specialties. And now today, as we're starting to ramp back up more on-campus services, we're still hovering about 40% of all of our physician group practice visits being telehealth, which is great. It's allowing us to care for patients in a new and different way that we're finding they also respond very positively to. So our physician group practice put in those measures. They also put into place a virtual outpatient COVID clinic. Similarly, we found that these patients didn't have places to go. Caregivers did not want to see them in their offices, and they could slip through the cracks and get worse and come back to the hospitals. So we provided 5,000 virtual visits for COVID positive patients that we had diagnosed within one of our facilities. And then in addition to that, here at Emory St. Joseph's Hospital, we have a congregational health ministry program. And what they are charged with is going out to the community and finding those people who come back to the hospital frequently because the care is so complex and they don't understand some part of what they're supposed to be doing after they get discharged, or they're just very, very sick. And so we focused on those people in the community. We changed them to focusing on everyone. So every single one of our patients that came through the hospital now got a telehealth visit with one of those congregational health ministry nurses to ensure they just understood the education we provided them and what their follow-up care needed to look like, and then connected them to one of our primary care group practices if they didn't have follow-up care. And then finally, one thing that we have across Emory Healthcare is an electronic ICU. So we have intensivists and nurses 24/7 monitoring our ICU patients remotely. And we've had that in place for a while. We also provide those services to some rural facilities who don't have the ability to have intensivists in their own hospitals. And we have found during the pandemic, many other rural facilities who are interested in seeing this electronic ICU brought to their facilities to ensure they can provide that in ICU level care more safely as well.
Okay. And Heather, this is a great transition for our next question because you spoke about the community. So many businesses had to redirect their focus to meet the needs of COVID-19. How will your hospital pivot to maintain its community engagement efforts? So Dr. Rivers?
Oh, sure. So, that's what we do, right? And, again, Morehouse School of Medicine is known for its social mission. So, I'm very proud of the level of engagement that we continue to have with our very diverse set of community organizations that we work with. As we, attempt to pivot and, make adjustments internally as well as externally through public facing measures, I think that, technology is going to be one of our mainstays going forward, not as a end all and be all, but primarily as a tool. I think Heather and both and Kathleen mentioned, the use of technology and sort of addressing some of the gaps that we see. And so, for us, it's going to be business as usual. We're going to continue to, engage the community through, multiple mechanisms, whether it's through our Office of Community Engagement or whether it's through, our diverse cadre of, lay health advisors that serve in many of the NPUs around Atlanta. Or whether it's through our community advisory board that is comprised of representatives from every NPU in Atlanta, Fulton and DeKalb counties, that will then work collaboratively with us to advise us on what needs to happen. The voice of the community is so important. We can stay sort of in our ivory towers and craft, approaches and strategies, but then get out in the community and find out that they absolutely do not work. And so we want to be as responsive as possible, and we want to hear from them. We want them to tell us what we should be doing and what their needs are. We can assume, but then, failure is something that you just don't want to happen on your watch. And so, that has been our approach, since the existence of this institution, and we'll probably continue in that same dynamic, whether it's in our, academic enterprise, our research enterprise, or even our clinical enterprise, because it's so key to hearing the message directly from from the community, especially the diverse constituents in which we serve. Again, as I made note of earlier, many are on the front line, either in the healthcare profession and or as essential workers. And so, we want to make sure that, when the measures come out, the evidence-based measures the CDC put out, that, our communities understand those measures and they can take the necessary actions and reactions, of course, of adherence to these messaging. We found it initially, there was some difficulty with communities understanding the message totally. We still had folks gathering in churches, still going to choir rehearsal, still had individuals still congregating in barbershops. And so, there was a gap there. I don't know if it was health literacy related in scope, but we know that the messaging needed to be clarified and brought in a different way to the community. And so, those type of strategies, I think, listening and then reacting, based on what we've heard, is our strategy going forward.
Thank you, Dr. Rivers. Dr. Funk, would you like to share your perspective?
Yeah, sure. I think, Dr. Rivers has hit the nail on the head. Is we need to be gathering data. We need to be connecting with our communities. We need to be doing that in every way possible. And Morehouse is doing a beautiful job. And I know, since the beginning, Northside had community outreach to educate people for how to protect themselves, when to come in. Our behavioral medicine unit immediately recognized that the mental health challenges in the COVID crisis were going to be tremendous in our community. And so they started a campaign almost on day one of outreach into our community, especially our Latinx communities, which is a lot of what is around our hospital, trying to give them the information they needed, how to access free mental health services, our primary care practices, because they were shut down by at least 50% and moving to telemedicine. They joined in that effort and they did what they could to get it out to, every manner of community service organization that they could connect with. And one of the things we did is we still have our COVID team has daily meetings where they're watching the COVID statistics because data is key. And we watching the demographics for our ICU patients, especially. We noted probably pretty early on, actually, and it's been pretty constant throughout, that 45% of our admissions to the ICU are Hispanic or Latinx. And so we particularly started an initiative reaching out to that community, trying to, get rid of the misinformation, try to, encourage social distancing. These are people who live hand to mouth, and so they have to show up for work. They're also, a lot of them, essential workers. And so we're, encouraging hand washing, wearing masks whenever possible. And more key is, because so many of them are in our ICU, is trying to teach the community to come in earlier before they're sick enough to need to be in our ICU. And on another note, I would have to say, from community outreach, it is currently impossible to separate the risks of the pandemic from the risks associated with the relevant protests over racial disparity and systemic racism. And so one of the things that Northside began is they're engaging our community on this topic. They're the Northside community itself, but they also gave a meaningful contribution to the Southern Center for Human Rights, which is a pro bono organization representing primarily African Americans, many of whom have limited financial resources. And their stance on that is that action is going to speak louder than words. And so, trying to do what we can to encourage everyone to do the hard work of understanding and closing this gap.
And Heather, would you like to add anything?
Yeah, my colleagues have hit the nail on the head. Everything they're doing is what we're doing. It's really about education right now. It's about providing clarity. With the word changing so frequently on the guidelines from the CDC, there's been so much confusion about what to follow and when. So it's just education and re-education and re-education. It's similar to everything that my colleagues are doing right now.
Okay. Yes, and we all know the community is the heartbeat of our work. So I'm glad to hear about all of your community engagement activities. So let's talk about the long-term impact. What are your thoughts about the long-term implications on healthcare? How will things change when you adopt the new normal for healthcare? So if Heather, you could start us off.
So I see the new normal changing a lot of things within healthcare. I could list many, many, many. I see us rationalizing services differently. See us going more towards centers of excellence where, we provide services in certain areas. Right now, if you have a large health system, you may perform services of like kinds across the entire health system. I see an opportunity for us to really look at where can we provide the best care, what's the right location for that care. I see us really taking a step back in healthcare and saying, do we need every patient to come into the hospital? Do we need every patient to come to the emergency department, to even our clinics? And how do we do a better job of getting patients to the right location? So do we do remote triaging like we've been doing during the pandemic? We've had a lot of resources put towards, do you actually need to come in and get care at the facility? Do you need a quarantine in place? Do you need to come to the emergency department? We can do that with other types of care. It's just not been something we put a lot of time and effort into previously. So I see an opportunity to get patients to get care in the right location in the future, which in large part is going to rely upon the telehealth technology that we've been able to develop during the pandemic and seeing that remain in place. And then I do see, because of the impact of the pandemic, I think we're going to see continued consolidation of services. We're not going to have as many rural hospitals. We are going to lose some of our physician practices. So how do we ensure that we don't see gaps in care? And that's going to be something we have to spend a lot of time working very hard on through telehealth and some of the remote technology to make certain that there's not further disparity placed on care going forward. Those are just some of the things I see happening, but there's a lot of adaptation, I think, for our new normal that we're going to continue to see.
Thank you, Heather. Dr. Rivers, would you like to share your perspective?
Sure. Likewise, similar to Heather, the list is very extensive. But, I think, for Morehouse School of Medicine, some of the takeaways from this is, looking at the role of technology and seeing how we could create portals of access to address some of the healthcare disparities that we see among our constituents. Again, primarily African Americans and Latinx populations are who we service, and more so African American, just given our history. And so better understanding, what are some effective intervention strategies for mitigating healthcare disparities as well as health disparities, because we really saw the disproportionate impact of this pandemic on populations of no reason on their own other than, it's just systemic barriers to really access to care. And so how can we do a better job in making sure that all individuals have access to care? Secondly, just being a liaison to the community, better understanding their needs in real time, and then being in a position to adequately respond to those needs. And then third, more collaborations. During this pandemic, I may have written at least 3 or 4 different grants with academic institutions around the state of Georgia. Most recently, collaborated with faculty at Emory School of Medicine on a PCORI grant, Patient-Centered Outcome Research Institute proposal that was submitted to basically institute a surveillance program. Of developing a spatial dashboard to identify hotspots around the state of Georgia, and then mobilizing resources to those different areas to immediately intervene before the hotspot become, a terrible spot. And then looking at, at our rural populations and how they're faring. As you heard from my colleagues, many of the hospitals are closing. Healthcare is already fractional in scope. And so, what things can we put in place? So we're collaborating with a clergy group, and we developed an initiative called Fishers of Men, where we're actually training clergy in rural areas for the dissemination of health messaging back to their congregants. And so we all know that the church is a trusted resource in minority communities. And so we're leveraging these unusual structures and places that, could be of immense benefit health-wise to these populations that are otherwise considered hard to reach. And then lastly, I'll say, I think we're going to see increased interoperability of our systems and how they talk to one another. Early on, we had a problem characterizing the true disparity because race and ethnicity data was not routinely collected in a uniform fashion. So we're going to see, more structure added to our data, and then more interoperability of our health systems being able to communicate with one another to ensure that, the problem is being diagnosed, it's seen in real time, and real intervention strategies can be put forth. And so, I'll stop there, but, the list is extensive, and I think we're learning, day by day in terms of, additional things that we can do much, much better.
And Dr. Funk, would you like to add anything?
Yeah, sure. I agree with both my colleagues. They have really good points on how this needs to change. I think one of the things to point out is that for all of us, society is going to see so many changes caused by the pandemic that will rival or surpass the amount of changes that we experienced as a result of 9/11, whether we want them to or not. We can't get away from that. We're going to have to embrace it. The changes that we're experiencing now, things like the use of telehealth, learning to think outside the box and create solutions on the fly, being nimble in the way we approach problems, really strategically cooperating and coordinating our resources and pushing the limits of what we thought we could do. I think we've gotten fairly complacent in healthcare with, one day after the next. And now this has shaken things up and made us kind of look at ourselves again and maybe say that we could be doing a better job of some things. Dr. Rivers pointed out, and it's a great point, and so I don't want it to be missed, is that these things, telehealth and all these, fancy tools and whatnot, they are just tools. You have to have the strategy first, and you have to have the data first. And once you have those things in place, then you can begin to create meaningful solutions. I think we need to see healthcare become more lean. We need to learn to wrap our arms around the patients through their full cycle of care to make sure that they're actually getting back to better health and that they're taking care of their chronic medical problems. I think we all need to be actively evaluating how disparity and the social determinants of health are keeping a lot of people from living healthy lives. With widespread unemployment, we're going to see a lot more uninsured patients now seeking care, because today in the U.S., insurance is mostly employer-based. So there are huge implications for the need to embrace greater efficiency in medicine. The new models of delivering care. Right now we're on target this year to have healthcare costs rise to 20% of our GDP, possibly higher given the fact that we have unexpected healthcare costs from the pandemic. And our outcomes are worse than most developed nations in most categories. So we need to be focusing on that. I think one thing, though, to be said is for now, we should anticipate new waves and peaks with the pandemic. We need to all be nimble and be ready to pull back on the opening up, pull back on, put our, negative pressure stuff back in place, all the things that we've kind of begun to roll back as our numbers are dropping. The waves are not likely to stop, according to the vaccine experts, until at least 60 to 70% of the population has a vaccine that is at least 70 to 80% effective. The Spanish flu lasted 18 months. So for everybody out there, we need to settle in, we need to be patient, we need to know that we'll get through this, and we need to follow the precautions. And quite honestly, if you don't like how it feels to wear a mask, you're going to hate the ventilator.
Ooh, great point. So we're going to enter our closing question before we open it up to the public. So we'll start ladies first. As we focus on forward thinking, what would you say is the biggest challenge or opportunity after COVID-19? And what does the future hold for healthcare? So Heather, can you start us off?
So I don't know if I see this as the biggest challenge because we have so many challenges, but one of the opportunities and challenges is to do a better job in healthcare using our learnings and translating that into better access, better care, bending the cost curve. We are really, really good in healthcare at looking at clinical outcomes, doing research clinically, changing protocols, getting those things in place that our patients need to get better care. We do a very, very bad job of doing things like, getting telehealth in place, changing care models, using resources differently so we can actually bend the curve. And we learned so much during this pandemic of what we can do in healthcare that I think it's both a challenge and an opportunity to figure out how to actually translate that into changing the healthcare system. And I think we'll spend time on it, and I hope that we all collaboratively can work on it and be more successful in the future on that.
Thank you, Heather. Dr. Funk, could you please share?
Yeah, I think I think our greatest challenge is also our greatest opportunity. I think it's all one and the same. I think the challenge is to close these disparity gaps, to improve the efficiency of care, we're going to need community, we're going to need legislative help, we're going to need help to make these things happen. There are a lot of barriers to the things that we know we need to make our care more lean and more patient appropriate. And so we need everybody involved. And this pandemic has given us such an incredible opportunity to reflect as a community, to take the same breath, the same heartbeat, and reevaluate our values as a community so that, everybody's so distracted all the time. And right now, with all this work from home and everything's been drawn in, now is our moment to kind of look at this and say, how can we be changing this? For the future of healthcare, we're going to likely find that if we start to measure what matters to patients, that we're spending a lot of money on things that don't even matter to patients. We need to start letting people define what health looks like to them and stop thinking about what we can do to patients and instead of think about what we can do for people. I think this is a real crossroads in medicine. And I think with help and support from our community, we can make some significant changes.
Thank you, Dr. Funk. I love your perspective. And Dr. Rivers, can you please share?
Sure. And I'm in agreement with what has been stated already. And, while it may be one of our biggest challenges, I think it's an incredible opportunity that we have before us. As they say, today's medicine is yesterday's research. For the past 20 years, NIH has spent billions of dollars trying to better understand health disparities and health care disparities. There's been centers of excellence. There's been multi-institutional, multinational collaborations all around better understanding mediators and moderators, so pathways to adverse outcomes, whether it's an incidence or prevalence or even mortality. I think we're at a unique nexus right now to really translate a lot of what we found in the research studies to benefit in the clinical setting, but also to the population and policy level as well. There's a lot of discoveries that have been made that can really help us advance and address a lot of the factors associated with disparities, either at the individual level or even in the communities in which they live. We understand that one zip code can determine how long they live. We understand that there are food deserts out here in certain communities right around these great academic institutions. And what are we going to do about it going forward? So we have this knowledge. I think, going forward, we're going to see more translation of research into a clinical setting to ensure that it is patient-centered and that it is meeting the needs of the patients. Because, again, I think Atlanta's poised to be a model, especially as it relates to how we address disparities among African Americans, the group that's disproportionately impacted by almost every chronic condition out. And we definitely see it in the context of cancer, where African Americans are more likely to not only be diagnosed, but then die from many of the cancers that, in some part are mostly preventable. And so what strategies do we put in place, and do we extend our efforts beyond the clinical setting and really embrace the definition of health by the World Health Organization, where it's not just the absence of sickness or disease, but complete mental and physical, social and spiritual well-being. And until we embrace that allows individuals to work and provide for their families and provide and be a good neighbor, I think we're going to continue to have these challenges before us. So again, I think we're at a unique time to really address health disparities and healthcare disparities. And I think we should definitely use what we have been finding really works through the conduct of research.
Well, thank you to our panelists. We are now going to open up the floor for questions from member and stakeholder participants. Okay, so we have a question from Mallard Holiday. What's the best way for area businesses to support your efforts? Heather, do you want to start us off?
Well, I definitely agree with the fact that taking action is what we really need right now. We need businesses to get involved in the healthcare community. We need to get, frankly, we need help with donations. We need fundraising in order to do some of the work that we're talking about today. We really want to make certain that we are making the change. We also need people to appeal to the legislatures. We need businesses and people to help us make this change that is necessary right now and help us come together as a community and push for permanence of these telehealth changes and looking at health disparity in a different way. So I think it's a collaborative, it's a partnership that we need from businesses in the community right now.
Dr. Rivers, would you like to share?
Yeah, I mean, I'm in total agreement as well. Collaboration is key, sharing of not only fiscal resources, but their ability to be a hub, if you will, for information dissemination or dissemination of other strategies that a different catchment area or a certain community may have need of. So just being a liaison, I think would be extremely beneficial into a lot of the work that we're doing. Oftentimes we try and decentralize a lot of our activities into places where it matter, and whether it's at a local business, a church, a barbershop, a beauty salon, or some other structure in the community, we try and establish this network, if you will, for the sharing of resources, for the collaboration of resources.
And Dr. Funk, you have anything to add?
Yeah, one of the first things, being a frontline provider and in the emergency department with these really sick patients, I want to thank everybody in the community for feeding our team, for keeping our spirits up. There are cards posted everywhere thanking us for the risk that we're putting ourselves at. So that is one thing that I would like all of your listeners to know, is that we truly appreciate it, and we really didn't get an incredible, there's not an incredible modality for us to be thanking everybody. So I really want to make sure that from the heart, from all of us, from all of our institutions and everybody who's been helping us, that we really appreciate it. The other thing, though, is education is really kind of key. And not just the legislative help, but start a conversation. Converse with whoever that works at the hospital, somebody that your neighbor is on the board. Let them know these things are important to you, because until we get an understanding and leadership that it's important to our community, these conversations aren't going to happen. And if we initiate the conversations, then it has less meaning, because we're imposing what we think the community wants on them. We need the community to come to us and say, these are the things that we think we need, and we need these businesses to help us educate and improve the health literacy. Just exactly what Brian was saying, which is to get the word out for what is health. Why do you get screening? Why do you have your chronic disease? Why do you refill your meds? These kinds of things will help to mitigate, advance of chronic disease into a unconscionable state. We just really need to work together as a community. So we could definitely use the help.
Thank you. And if you would like to submit any questions, please do so on Facebook or YouTube. Okay, we have a question from Bill Baker. How does the wearing of masks potentially impact herd immunity? Who can answer this question for us? Anyone?
I'd be happy to take one on.
Okay.
Yeah. So herd immunity is, the thinking is that if enough people get it and enough people get antibodies to this, then we're going to not all get as sick. We've seen this in a number of disease processes. The problem with coronavirus is that we don't know exactly how herd immunity works. We have seen people get sick with COVID-19 and then get sick again with it. And so having been sick does not necessarily confer the immunity that we think of, like getting the flu in one season. Generally, you're not going to get that flu again in the same season. But COVID-19 works a little different. The coronavirus is a really tricky virus. And so all coronaviruses are a little bit tricky this way. They just don't all make us this sick. And so the concept of herd immunity, that's why you haven't heard, Dr. Fauci talk a lot about it, is because we don't know what role that plays yet. And so if you wear your masks and you don't die of this, we will all be able to look back in retrospect once the vaccine is here and start looking at the data. That's what it's going to take to know whether or not there is even herd immunity in respect to the coronavirus.
Thank you, Dr. Funk. Any more questions? Okay, we have one from Sam Farmer. For care that can't be addressed via telehealth, how do you mainly foresee rural areas compensating for the lack of available care in these areas? Anyone would like to address this question? So pretty much about telehealth in rural areas.
Yeah. So one of the ways that I can tell you that we're working in that area is by establishing partnerships and relationships across the state of Georgia. We are going into these communities as a healthcare system and not trying to acquire the facilities or the physicians in those locations, but trying to truly collaborate and say, what can we do for you? You can provide care in your community for a lot of the things that your community need right there. So how can we help you with those local resources? So whether, it be telehealth, in some instances that works perfectly, in others it doesn't. So we have specialists that rotate to our partners in more rural communities. So we may not have a full-time physician that lives and works in that area, but most likely for certain specialties, that area doesn't have the need for a full-time person. But can we do a better job of rotating people through areas so that we can better serve the communities where they live? And we're seeing a lot of success with that.
Thank you, Heather, and thank you for those questions. Dr. Funk, Dr. Rivers, and Heather, thank you for sharing your time and insight as healthcare experts. We appreciate your leadership and commitment to providing the best healthcare for all Georgians. On behalf of the Dunwoody Perimeter Chamber, we thank all of you for participating. We look forward to joining with you again in 2 weeks, which is June 25th, for the finale session, a conversation with the mayor of Dunwoody. Please visit www.perimeterchamber.com for information and registration. Thank you again.